Hello, and welcome back to this episode of This Healthy Life podcast. I've got a great guest today. I have Dr. Todd Maderis, and we're going to be diving into all things long COVID, and that is just the tip of the iceberg. We're going to be diving into what might be some underlying conditions that are keeping you sick once you've had COVID. And so very excited to get your information today. Dr. Todd Maderis is the founder and medical director of Marin Natural Medicine Clinic in the San Francisco Bay Area, and he approaches chronic illness by really uncovering what your root causes might be and what underlying conditions are there. So excited for you to share your wealth of knowledge, what you've experienced working with your own patients. And yeah, I would love to kind of just dive into all things infection and COVID today. So welcome.
Great. Thank you for having me.
Absolutely. So I'd love for you to start just with a brief intro, a little bit about yourself, your background, and your practice that you have there in the Marin area.
Yeah. Well, like you said, I'm in the San Francisco Bay Area. I'm across the Golden Gate Bridge in Marin County, and I've been practicing here for about 16 years. When I first started practicing, I had a very general, functional naturopathic practice where I'd see people with thyroid issues, adrenal issues, digestive disorders, and over time, I began to see more and more complex patients, people, that were maybe falling through the cracks of conventional medicine. So they start seeking out alternative options. And eventually someone showed up with a Lyme result, a positive test that the ordering physician really didn't know how to interpret. It was back when I think IGeneX reports were a little more complicated to read. And one thing led to another, and the next thing you know, I was on a plane to a conference, a wonderful Lyme conference, and that really shifted everything in my practice. That was about 12 years ago, and nothing's been the same since. And then in about 2013, I was at an ILADS conference, and there was a speaker that was presenting on mold illness. And typically those conferences had been everything related to Lyme, and I couldn't understand why there was someone there speaking about mold. This is Joe Brewer, who's an infectious disease doc. And, it turns out that a lot of mold related symptoms are similar to Lyme, and, various other, they obviously go hand in hand. And once again, that completely shifted my practice. And once you hear something, you can't unhear it.
I know, right? And then you see how intertwined it is too, because it's like, it's not like you just have mold or you just have Lyme. Like they all just seem to kind of mesh together and overlap and cause all sorts of chaos in the body.
Yep. So it's been over a decade of treating people with chronic illnesses. And, I was just reflecting on this a few minutes ago, and it's like you have to stay very curious in this field. You have to keep learning and discovering, and kind of what gets you up every day to try to help your patients feel better. It's what motivates me, and it's a lot of fun.
Absolutely. Awesome. Thank you for sharing that. So you got your start in Lyme and mold, and then in 2020, we started getting a whole new fun little infection to kind of add to the list in the pile, right? So, so many people, as we know, once they had COVID, ended up with long COVID. So I'd love for you to just kind of give a little bit about how that shaped your practice, what sorts of symptoms people are coming in with long COVID, and what you've kind of noticed in your own practice treating those kinds of patients.
Yeah, it's obviously, I think in our field, people that had already been treating chronic infections, whether you were from the Lyme disease, a bacterial infection side, or chronic fatigue doctors that, were used to looking at things like Epstein-Barr and HHV6, cytomegalovirus, we were familiar with how to treat chronic infections. Of course, there's a lot of ways to do that, but, we were accustomed to it, being a persistent infection, which obviously conventional medicine really wasn't aware of, and kind of did our field a favor in helping to recognize that it's, infections can persist in people. And, over the last, I guess we're nearing 5 years now, people present differently. Everyone, fatigue seems to be the common thread amongst everyone, brain fog, headaches, digestive symptoms in folks, there's a myriad of symptoms that can manifest. You know, in the interest of trying to help these people get better, we would do very comprehensive testing, looking for other, other infections maybe that had reactivated, or toxins that had compromised their immune system. And of course we would find things, and it wasn't like everyone had the same underlying foundation. I think, some of my patients had mold illness and they contracted COVID and symptoms persisted. Other people, they did have tick-borne infections. And I often will joke with patients, I've yet to meet a long COVID patient that didn't have something else going on before they got COVID. COVID's just tipped them over the edge. And then, it's easy to point the finger at COVID because it was the most recent infection, but you really have to address the whole underlying picture if you're going to help someone recover.
Yeah.
Yeah.
Absolutely. Awesome. So let's talk a little bit about people that are recovering from long COVID. What sorts of things you mentioned that you're seeing that people have like tick-borne infections and mold and things like that. Do you have kind of like a protocol that you're using with people, and like we have to address toxins first and then go after infections, or what are you seeing is kind of working? And do you even have to address COVID at that point, or is clearing out these other things enough and then those symptoms start to resolve because it's kind of just your immune system going a little haywire?
Well, I definitely, generally speaking, when someone has a chronic infection and they also have a toxic burden, whatever the makeup is, I always want to address toxins before I'm addressing infections. A lot of these toxins suppress the immune system, and it makes it very difficult to clear an infection when your immune system is compromised. They also, toxicants can trigger an inflammatory response that makes it difficult to know what remains. And so if you can detoxify someone, really support their ability to reduce whatever burden they have, they're going to recover a whole lot quicker with any chronic infection. I think with COVID, there's been a lot of theories in the last 4.5 years of when or why long COVID persists in folks. We've found persistent virus, we've autoimmune, trigger an autoimmune condition, an inflammatory response. There's been reactivation of other infections, mast cell activation syndrome. But I think something that's overlooked is the biofilm component to COVID. And as some people say, there's long COVID is really a biofilm issue. And I love to test patients for whether or not they're overproduced fibrin or they have a compromised ability to break down what's called fibrin. Fibrin contributes to biofilms. And what's interesting is about 20% of the general population has a genetic variant where they accumulate too much fibrin. Well, with long COVID, early on, the numbers have changed a lot, but probably under 20% of people that get COVID end up with long COVID. And so I like to test my patients for a coagulation panel with LabCorp and determine if they have one of these gene variants that either contribute to too much fibrin production or inability to break down the fibrin. So if the virus is walled off in this biofilm, there's the persistence.
Mm-hmm.
Yeah.
So say that you are able to do this panel. I'm just curious, like, can you be prophylactic or, preventative with it? Like, say you've done the panel and you know that you're one of these people that produces more fibrin. Are there things that you can take just kind of prophylactically, or if you get acute COVID and like you just get diagnosed or just find out you have it, are there things you can take to help break down this fibrin and prevent those biofilms from forming, or is your body just going to do it anyways?
No, absolutely. And infections in general and toxins, anything that drives inflammation is going to drive the fibrin production. And so even if someone doesn't have the gene, and the inflammation that comes from the infection will cause fibrin production. And so if you remember, a lot of people, there was, kind of a storyline of taking nattokinase to help break down the spike protein. Nattokinase is a fibrinolytic enzyme. It's not necessarily the best one to take. I typically prescribe lumbrokinase in the form of a brand called Boloke. But if someone does get COVID, it's probably a really great idea to, jump on a fibrinolytic enzyme. But if they have one of the genes where they overproduce fibrin, they're probably going to be on some blood thinning medication. These are coagulation disorders like factor V Leiden. And if someone has that, then they would benefit from, sort of a lifetime of thinning their blood. Or if they don't break down the fibrin, they would benefit from being on Boloke for, a good portion of, or maybe the rest of their life.
Mm-hmm, mm-hmm. And is that something that you experience issues with at any point in your life? Or is that something that as you get older, you start noticing more issues with the fibrin and the clotting or the coagulation, if you will?
Yeah, it's a good question. I think a lot of people don't realize, this excess fibrin accumulation in the body can lead to a variety of symptoms that sound very familiar, things like brain fog and fatigue, but also POTS and dysautonomia, and then even some more unique symptoms like maybe pain in the teeth, like teeth sensitivity, or, we'll see kind of a stiffness and achiness in people. As time goes on, if they have too much fibrin, it starts to form what's called fibrinogen in blood vessels. And so what someone might think is normal aging, whether it's fatigue or, cognitive issues as they get older, may be a byproduct of this fibrin issue. So the other day I saw a woman, she's 75 and kind of a unique patient. She was diagnosed with Lyme before I ever met her and was treated with antibiotics. And since I've seen her, she sort of, I see her peripherally and she just takes antibiotics because it keeps her symptoms suppressed. Every time she stops them, everything comes back. Well, they're not working. They're not killing the infection. They're basically causing the bugs to go into dormancy. And we ran this panel on her, and sure enough, she had the factor V Leiden. So she's 75 years old, never knew that she had this. And, your general doctor's not going to typically run it unless someone runs into a clotting issue. It probably doesn't get tested.
Mm-hmm, mm-hmm.
Yeah.
And so it's just an easy test it's just a blood test with LabCorp, you said, that you run a panel for, and that can give you this information.
Yeah, there's a panel that was developed or put together by a woman named Ruth Kriz. And Ruth has practiced for about 40 years, and she's wonderful. And she put together this panel called, the number is the code number is 505443. And the benefit of the panel, well, first of all, you want to run it through LabCorp because LabCorp owns a hematology division called Esoterics. And her panel reflexes to the gene. So you have to have an abnormal marker. And if you do, then it runs the genetic variant, and you can determine if someone has the gene or not. And that's the best way to get it done. So I saw a woman yesterday, she's, I think, 35, and she has a double or two copies of this. It's a gene deletion. And so right away she was talking about her mom and should her mom get tested. And she said her mom's had a lifetime of issues. And I said, well, yeah, you have two copies, meaning you got one from your dad and one from your mom. So she at least has one copy. It's fun to see things like that unfold where other people benefit and get to understand like the why behind it. But, in chronic illness, I think it's been a real big missing piece of the puzzle and a reason why these infections can persist in people ongoingly.
And so do you think this is affecting other conditions as well? Because let's break down biofilm for a minute. Obviously, Lyme loves to hide in biofilm. And one of the reasons it can just persist so long and kind of just hide in your body. Are you thinking or finding that with COVID, that might be the same thing, that there's actually still live bacteria in this fibrin, in this biofilm? Or do you think it's some of these other infections that have come out that are causing some of these more long-term symptoms, and the fibrin is just kind of causing some additional inflammation in your body? Or what's kind of your thoughts? Are we dealing with another Lyme that's just hiding out in biofilm, or what do we got going on here?
I mean, I think if you're in the 20th percentile that has one of these genetic variants, then whatever infection you're exposed to, potentially it persists. And so it's everything from, even things like strep infections in pandas, kids with pandas,
Mm-hmm.
to like SIBO. And,
Mm-hmm.
think about SIBO, how many people get treated for it and they do fine
Mm-hmm.
for a while and then it comes back.
Yeah.
And I also see it in urinary tract infections. Like
Hmm.
I don't, a lot of my patients, young women, will
Mm-hmm.
suffer from UTIs, and
Mm-hmm.
not necessarily because they're getting them right after intercourse. It's these bacteria will live in a biofilm in the bladder, and eventually, sometimes the bacteria dislodge and break loose and you become symptomatic, and someone takes an antibiotic. It's basically suppresses the bug. If it isn't the right antibiotic. They feel better, assuming the infection was gone, but then a couple months down the road, they get another UTI. It's because it basically, the biofilm issue. So I think a lot of these, if 20% of the general population has this variant, I would say in my practice, it's probably 60 to 70% of my
Mm-hmm. And
patients
that's why
so
people are
far.
becoming so chronically ill with these infections that just persist and kind of keep
Maybe
coming
one of the
back.
reasons. Yeah.
Yeah,
Yeah. I think,
yeah,
environmental toxins, of course, could be folded in
for
there,
sure.
genetics, other genetics
Mm-hmm.
as well. So,
Mm-hmm. And
yeah.
then what about mast cells? So you had touched on mast cells a little bit, and I feel like, so I got Lyme in 2012. I got diagnosed in
Hmm.
2014. So I was kind of in the Lyme world for a while. And
Yeah.
about 5 years into it, I feel like is when mast cells started just becoming a big
Hmm.
thing. And I almost feel like no one was really dealing with it, or maybe people were dealing with it. We just didn't know what it was. And then all of a sudden, everybody was like having mast cell activation. And now I'm hearing a lot of that in some of these other conditions like long
Yeah.
COVID and things like that. And just so many other conditions that might be affected by mast cells. What's kind of your take on what's going on with mast cell activation? Why is that so prevalent in people with some of these chronic infections?
Yeah. Mast cell definitely is a buzzword in diagnoses in the last 4 or 5 years. Mast cells are normal immune cells in our body that typically deal with allergic, antigens, and but with chronic infections and a persistent inflammatory response, sometimes these mast cells become more, it's an activation syndrome. So they more readily will release their contents. It's not just histamine inside of a mast cell, but I think we're up to 2,000 mediators that get released.
Wow, that's a lot.
And it
That's a
is a
lot going
lot,
on there.
right? And depending on where they're located or
Mm-hmm.
which ones get triggered in the body, it could be a gut related issue. It could be a skin issue with mast cell, there's a couple of things I think is going on. First, there can be genetic variations that cause people to be a little bit more reactive or prone to a mast cell degranulation. And then when we have all these other Lyme toxins and infections in our body, they irritate the mast cells and cause a release of the content. So I sometimes think of mast cells like the beehive, and something pokes the beehive, and it's still important to address the underlying piece. When you do, I think people's mast cell issues can be tempered and less reactive.
Mm-hmm. Mm-hmm. Absolutely.
But it's
Uh,
an important part of treatment, right? I mean, you still want to make someone feel better while they're going through that treatment process, and a lot of different therapies out there that we use. And
yeah. Are you
yeah.
finding that as you kind of treat these infections, treat these environmental toxins, that the mast cells start to correct themselves on their own? Or then once you kind of get that, viral infectious load and toxin load down, then do you have to do some sort of additional therapies to kind of reset the mast cells, if you will?
Well, I think when you reduce the burden, you quit poking the beehive, that you'll see a reduction in the reactivity. Um, but it can be really challenging, right? I have some patients that are so reactive that they can't take any medications to treat the underlying cause. So for some of them, it's almost like, you're propping them up just so they can get through their daily life. And they're just basically surviving. And, it can be really challenging. Sometimes there's gut related issues because of the mast cell content, high levels of mast cells in your gut. Someone that has like leaky gut, for example, gut inflammation, they're going to exacerbate the mast cell reactivity, and that can become a little bit of a vicious cycle. So I always like to look, at things like bacterial dysbiosis in the small intestine, and test patients for leaky gut and make sure, correct those imbalances if they're there.
And so let's talk a little bit about the testing. So you've touched on some items a little bit, like, kind of working with the gut and then also doing this panel to see if you're one of the 20% lucky ones that have
Yeah.
the fibrin condition. So what other kind of testing do you like to use in your practice when, say, a new patient comes to you and is like, hey, I have long COVID, and you're like, all right, let's break this down and dive deep and
Yep.
see what's really going on here. What's some of your go-to testing that you typically test patients for?
Yeah, I mean, a lot of it's dependent upon the history, and so I always can hear old mentors of mine saying history, 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 and it really does start there. If someone thinking of someone I saw this week, and it's like grew up trail running or spend a lot of time in the woods, then of course I'd want to test them for a tick-borne infection, even if they don't recall a tick bite. Even here in California, we have ticks.
Oh yeah, I got it in Yosemite. I'm like, it definitely is here.
Up in the Sierras,
Yeah.
high elevation. Yeah. So we have the coastal range here, and it's funny to still hear conventional doctors tell patients, specialists in particular, will say, "Oh, we don't have Lyme on the West Coast," and it's like ticks were being studied in California at the same time Lyme was discovered in Lyme, Connecticut. So in the 70s, there was an entomologist from UC Berkeley studying ticks in California, Northern California. And so it's been here for a while. And if someone has that history, I'm going to do a full IGeneX panel on them. If someone maybe has a history of exposure to a water damaged building, or they have symptoms consistent with it, I always want to do a urine mycotoxin test. It makes me think of people that I'll see that have maybe seen a half dozen to a dozen doctors before I see them. And, sometimes these things get overlooked. And if something does get overlooked, it could be the missing piece of the puzzle. So I get a little OCD about the tests that I use and the proper way to collect it, which labs over other labs. And, I think of it like tacks in the foot. If you've got 6 tacks in the foot and you find 2, you still have 4 tacks in the foot. You have to get the full roadmap to help someone get better.
And then are you finding other environmental toxins such as like heavy metals or, other types of toxins in our environment are contributing to this as well? Or kind of the key factors are usually tick-borne disease and molds that are really kind of tanking people down with long COVID?
Yeah, everyone's a little different. And things like heavy metals, I think, are probably one of the most overlooked toxin that people either don't get tested for or don't get properly tested for. We were talking about heavy metals and, in the 90s and 2000s, and I don't know if it's lost some of it, but people still, people can have a high mercury burden, for example. I post a lot of new research on social media on my Instagram account. And I just, in the last, I don't want to say 6 weeks or so, I've seen a number of studies come out about toxicants, like a heavy metal study and how it contributed to long-term or chronic infections in people. You never see things like that. But the heavy metals are a big one. We have some toxins are what they call persisters and others are non-persisters. Some, if you just quit being exposed to them, like solvents tend to be that way, then your body burden goes down. Others, like heavy metals, they'll stay in your body. So, for example, the biggest source of mercury is from eating large fish like tuna and ahi. And
everyone loves their sushi.
Yeah.
My mercury was off like through the roof, and I used to eat so much sushi, and it was always like tuna or the high mercury fish. I know better now.
Yeah. It makes me cringe. But some, people could have maybe have been a vegetarian for the last 20 years and not eating any fish at all and still have a high mercury burden. And when you look at the effects of mercury, like we know elevated mercury causes Hashimoto's or can contribute to Hashimoto's. How many people are walking around with Hashimoto's that never, ever get tested for mercury?
Absolutely.
And so, though that's one of the persistent toxicants that I like to test patients you provoke it, just like I provoke a urine mycotoxin test with glutathione. You have to provoke metals because they live deep in tissue. They get stored in connective tissue and bones. So you have to properly
lure them out.
You have to pull them out through the urine, and that's how we get the accurate information.
Yeah. I did a lot of chelation in my journey. My lead and mercury was like past the line. It's
Good for you.
The highest it could be, but it's come way down. I barely have any. Well, I have a little bit, but I don't think you ever fully get rid of it 100%, right? I mean, we live in a toxic world, but as long as you're kind of monitoring it and doing detox things and trying to stay on top of it. So
yeah. With a provoked sample, you're always going to have a slightly elevated level. I think that's one of the biggest misinterpretations of that heavy metal test that even most physicians don't recognize, is that with a provoked sample, the reference range on the lab is for an unprovoked sample. So if you're provoking it in any way, shape, or form, it's going to look slightly elevated. So my cutoff I like to provoke with IV chelation. The oral chelation doesn't work as well. And if you provoke with IV, a mercury under 15 is normal and a lead under 10 is normal.
Okay, good to know.
So it looks like it's high,
it looks bad, but it's not so bad. Finally, some good news.
Low levels aren't. Yeah, exactly.
Awesome. And then, so I want to talk a little bit about some of the reactivated viruses. So, like Epstein-Barr is mono from the past, and shingles can come back to kind of haunt you later in life from chickenpox. So, with COVID being a virus, is there any kind of thought or speculation that it can be one of these viruses that maybe, we haven't had it around that long, like in 10, 15 years, are people going to be having a resurgence of some sort of modified, reactivated virus, or is this a different kind of virus that we don't need to worry about that?
Well, these viruses tend to want to stick around and, get inside of cells and basically take over the machinery so they can survive. There's a concept of what is called successive infections. And I see that in my patient population where people, if you really dig into their history, someone might have, say, been exposed to Epstein-Barr, they got mono in high school, or were told they had mono. And then, someone might have get mold or exposed to mold in a dorm in college. And then they get COVID in their 20s. And that's like the third hit or the successive exposure. Could COVID do that down the road? Absolutely. I wouldn't, we may see reactivations. I'd say that's, the total, infectious burden becomes part of your, you could say, microbiome or maybe pathobiome. And so at the end of the day, I think it's all about keeping your immune system strong and, reducing, the word, boosting your immune system I'm not a big proponent of. I like to remove what's there that's undermining your immune system. So if we're doing all the proper things like, good diet and lots of, plenty of rest and low stress, the things that we're supposed to be doing, hopefully we navigate the world without reactivations. It's always that perfect storm of, a period of intense stress
Absolutely. Yeah. I mean, it's so common, especially like in the Lyme world. I'm like, for me, it was like, oh, I got Lyme. But when I look back and once I kind of really started diving into what was going on and what I needed to clean out, I was like, for years before I got bit by the tick, I was already, depleting my immune system, like the high exposure to metals. And then I lived in a moldy apartment in grad school, and we literally had a flood, and they came in and lifted my carpet, put box fans under it, let it dry for a day, and put it back down. And then I started having chronic sinus infections and weird food allergies. And I felt better when I moved out, but it was just like that had already taken such a hit on my immune system. And then, as you've described on this podcast, just kind of like that cumulative effect of just these new things piling on until your immune system just gets to a breaking point and can't keep up anymore. And then everything comes out, right?
Yeah, that's it. It's a confluence of events. And I think that, especially in the earlier days of treating Lyme, it was easy to be myopic and focus on just the bug. And we, a lot of, especially the older Lyme physicians would, try to hammer the bugs with antibiotics and more is better. And in my experience, if you keep asking why and why, wanting to, discover the underlying issues, I think you recognize that it's rarely one thing, and it's easy to get. I spend probably too much time thinking about this stuff sometimes, but at the end of the day, you could, for example, even just testing, right? Someone gets told they have something based on a test. Well, how, what's the validity of that test, and which antibody is it? And is it truly an active infection, or is it a memory antibody like an IG? So it gets a little bit tricky. I think we're still, people would in the Lyme world would say we don't have good tests. And I mean, the tests are much better now than they were 10 years ago. It's also the doctor's duty to interpret it properly and determine. But if you get siloed into one thing and you spend the next 18, 24 months going down that road trying to kill that one thing, but you're missing the bigger picture, then that's where people end up, with the chronic issues. So half the battle is getting a proper assessment, which I think a lot of us, patients probably in particular, spend too much time seeking the magic therapy. And at the end of the day, they may be going down the wrong road completely, or not looking at the total picture. And, so these are complicated illnesses, and that's why we call it complex chronic illness.
Yeah, absolutely.
Yep.
Awesome. So I want to switch gears a little bit and talk about genetics. So you do a lot of work with like genomics on your patients and kind of digging into what's going on genetically that could be predisposing them for some things. So, obviously there's going to be some genes that affect a person's ability to fight chronic illness or detox, like particularly like the HLA gene, which I think 30% of the population has, and probably in your practice, even higher, right? I mean, most people with Lyme and mold have that. If you can share a little bit about maybe that or other genes that you're finding that are affecting people with chronic illness, that can be kind of another piece of the puzzle that they can uncover and see if they need to support that.
Yeah. So I think genetic testing has grown up a lot in the last, I guess you could say 8-10 years. People probably can remember when we first learned about MTHFR, and people would take their 23andMe and run it through some third-party website and get your SNPs. But then we didn't really know what to do with those SNPs. Now, I'd say more recently, I've taken a renewed interest in genomic testing because it's gotten a whole lot better. And what we can find, we understand that there's certain genetic, you could call it variations or polymorphisms. And some of these genetic polymorphisms interfere with, they could determine how your immune system responds to an infection, for example. So for some people, they might have more of a allergic type of reaction to a bug, whereas other people might have an inflammatory response to a bug. There's genes, like there's an interferon gamma gene that can determines if blood vessels leak. And so people, if they have this interferon gamma variation, then the bacteria disseminates or spreads throughout the body, which can, contribute to more of that, widespread chronic issues with Lyme. There's a gene that mold can trigger that affects mitochondria. It basically shuts off mitochondria if someone has exposure to mold. So there's these variations and that you can test for. I use a wonderful lab that also provides interventions. So they've dug into the research and said, okay, with this gene, if you have this variant, what are the natural therapies you can use to correct or support that gene so that people's immune system does work better or isn't so inflammatory? Or there's another gene that interferes or affects detoxification of mold and mercury from the brain. It's called ABCC1. And so if you have a variant of that gene, you're not going to clear mold out of your brain. And those are the people walking around with, persistent brain fog. So kind of high level, my perspective at this point, and I'm just diving into this, is that it's the, our genetics or genomics, you could say, plus what we might call exposome, which is infections, toxins, everything we're exposed to, is what contributes to the illness or disease that, people walk in the door with. And we tend to focus on the infection and the toxin, but we're not really, fully exploring the genomic predisposition.
And see what might need some extra support to even tolerate some of the treatments, right? Because like so many times, some of these people are just like you mentioned, like so sensitive, and maybe it's that pathway that's just not working correctly, and correcting that first, and all of a sudden you can tolerate some of these treatments or some of the detox, which can be really intense when you're going through it and you're that depleted already.
Yeah, yeah, there's a lot of really great genes out there, and where the lab I use is called Intellex DNA, and it's not available yet, but they're working on potentially doing a Lyme related genomics panel. So there's a lot of different panels within the Intellex DNA portfolio, and but so many of those pertain to both toxins and how we clear things out of our body, and infections and how our immune system responds or even deals with the infection. I don't do the HLA-DR testing anymore. In kind of in my circles, a lot of the mold physicians really found that it didn't, some of the sickest patients didn't have HLA-DR issues. Some people that fully, had no symptoms at all did have one of the, what people called the dreaded gene. So fortunately or unfortunately, that theory never really didn't seem to hold water.
Okay. Awesome. Good to know. I'm glad to know that there's these other panels though that can give you so much more insight, because I think that's such a big piece of the puzzle too, right? Like you said, everybody is like so unique and we all have different genetics. And so like what is holding us back personally, or like what's not working correctly in our body that we can help support in order to have some of this healing take place. So awesome.
Yeah, I think we're getting closer and closer to, what is cracking the code? We're getting closer and closer. And I think in medicine, it's easy to get complacent. It's easy to continue doing what you're doing. We all get busy, and it's how you spend the rest of your time, learning, discovering, staying curious, that allows you to come back in, your office the next morning and help your patient. And, so it's, in 10 years, we'll be closer to cracking the code. Maybe we'll be, but right now, I've seems like things are really moving in the right direction when we take this bigger perspective approach.
Awesome. We have time for one more question. You kind of answered a little bit of it already. My last question was going to be, what do you kind of see in the next like 5 to 10 years, kind of the future being, some new treatments that are coming up, or some things that you're excited about, especially in the world of, long COVID, tick-borne disease, and some of these chronic conditions. Where do you see things kind of going in the next 5 to 10 years?
Yeah, gosh, a lot's happening in the world right now. We may have some, it'll be interesting to see where the, our governmental influence goes. But, in my smaller circles and organizations, I think there's a lot more, it's like when I go to the big international Lyme conference, we're no longer just talking about Lyme. We're talking about, mast cell and mold and other issues, trauma and the role that it plays. We're exploring other therapies besides antibiotics. I've been using SOT in my practice, and I'm finding it extremely helpful. Just before we logged on, someone contacted me and asked if I wrote an article about SOT on my website, and they wanted to republish the article because they saw a lot of value in that therapy. So it's, things are always unfolding. I think there's always going to be the conversation of we need better testing in Lyme. At least we need better testing, better antibiotics. At the end of the day, what I often say is I have to, my job is to help the person that's sitting across from me right now. I might not be able to wait 10 years for the testing's good. Doctors, we can get a little, lazy and rely too much on that, but you have to think about all of it. and it's our job to make the assessment. And so it'll be interesting to see where things are in 5 and 10 years. But I think between genomic testing, some better therapies, I'm a big proponent of how mitochondria is affected in these chronic issues. And so we use a lot of intravenous phosphatidylcholine in my practice to help repair mitochondrial and cell membrane. There's a mitochondrial researcher named Bob Naviau, who's been studying chronic fatigue for, I don't know, a long time. And Dr. Naviau says that, chronic illness persists because healing is incomplete. Like, you can remove the bug, you can remove the toxin, and someone can remain symptomatic. I think what we've always, or the physicians have told patients is, well, you still have symptoms because the bug is still there. Let's keep treating the infection. At some point, you need to make the decision that, when do we go on and start healing and repairing? I had a great example of that with a patient in the fall, and we really never she tested positive for Lyme and Bartonella and mold, and she didn't really respond to those treatments that well. And so I would say we didn't pursue those long term. And I started her on a cell repair protocol, IV protocol, and it completely reversed her chronic fatigue. And her life, she had dropped out of grad school. She had really struggled and wasn't participating in life, moved home, lived with parents, could do one thing a day basically. And now she's looking for work again. And so sometimes it's, you have to pivot and also focus on the healing aspect of recovering from chronic illness. And
yeah, that was definitely my experience too. Because if I did a lot of protocols for like 2.5 years or so, and it was like, focused on detox, but also killing and things like that. And I just kind of plateaued with it. I was like, all right, I'm doing all these treatments. I'm not really feeling a change anymore. I was like, I have to do something different. So I switched gears and went more into like, let's start to repair the tissues, more immune modulation, and kind of like resetting my immune system. And I ended up doing stem cells from my own fat. And that was what finally got me to the finish line, and kind of just really went in and repaired everything and kind of reset my immune system. So yeah, I think a lot of times it's so easy to just blame like the bugs or the infection, like why you still feel sick. But like a lot of times it's just your immune system that like needs a reboot,
Yeah. And the oxidative damage that occurs from these infections and toxins, they damage cells. And ultimately, I think that's why we were sending blood samples to a lab in Germany and measuring mitochondrial function and something called DNA adducts. And anyhow, you could see how basically someone's cellular biology, you could determine how damaged their cells were. So even if the infections had resolved, the patients were still symptomatic until we helped them heal on a cellular level. I often say, it's our cells make up our tissue, our tissue makes up our organs. And then of course so you're really only as healthy as the health of the cells.
Yeah. You're building blocks basically.
Yeah.
Amazing. Yeah. Awesome. Dr. Maderis, thank you so much for sharing all this amazing information. If people want to find you and find your practice, what's the best way to reach you?
My website's Dr. Todd Maderis. I like to write and share information there. In social media on Instagram, at Dr. Todd Maderis. On X, I think it's Dr. Todd. Awesome. But I do share a lot of new research on social media. I like to keep up on it, and I hear from people all over the world that that are struggling in their own respective country, and they appreciate so it's a little pet project of mine.
Awesome. And we're going to link to everything in the show notes as well, so people can find you there. So amazing. Thank you so much.
Yeah, thank you for having me.
Absolutely.